Hi. I'm Anne, so we'll get started here. I have Danny. You go by Danny? Danilo? Okay, so Val called you Danny, sorry. I have Danilo Concepcion. He has been a dialysis practitioner since 1975. He is experienced in the clinical, technological, research, and administrative areas of dialysis. He's an executive committee and project committee member for numerous dialysis-related organizations. He has been published in numerous professional journals and has been a contributing author on several dialysis manuals and APIC Elimination Guide, a guide to the elimination of infection in hemodialysis. And he has also been a member of the Renal and Disease Detoxification Committee since 2000 for AAMI, the Association for the Advancement of Medical Instrumentation. He's a member of the American Society of Nephrology and the CDC Prevention, the Centers for Disease and Prevention Nephrologist Transforming Dialysis Safety Project Committee. He is also on the editorial advisory board for Nephrology News and Issues and currently on the medical review board for the ESRD Network 18. So welcome, Danilo. And Judy Kirk is a nephrology dietitian with Rochester Regional Health. She completed her Bachelor of Science degree at Pennsylvania State University and her master's degree at St. Joseph's University in Philadelphia, Pennsylvania. She has over 20 years of experience in renal nutrition. Welcome, Judy. So, I guess I should... kind of weird reading my own, but I'm a nurse practitioner with Kidney Care and Transplant Services in New England since 2019. Prior to that, I was a hemodialysis charge nurse for approximately 10 years. I currently serve as the Assistant Program Director for the Nephrology Fellowship Program at UMass Chan Medical School at Bay State Medical Center in Springfield, Mass. There I do a lot of dialysis rounding, and I also work on the inpatient side, placing central lines and mentoring other APPs and fellows and residents. So we're going to get started here. Danilo received a consulting fee from Diality for advisor role in his area of ESKD, but Judy and I have no disclosures. So in terms of objectives, we're going to compare the unique roles and responsibilities of each dialysis team member, identify strategies for effective interprofessional communication during rounding, and apply collaborative approaches that enhance patient-centered dialysis care. So everyone take out your phones because we're starting with some polls. What is your profession? Okay. So about a third of us are social workers, some dietitians, a couple nurses, some learners. There's at least one other APP here, and a physician as well. So we have a good blend across the dialysis milieu here. Sorry? Hold on, I thought there was another poll that Val had, but maybe not. Oh, okay, she didn't put them in the slides. There was supposed to be another poll. So I guess we'll get started here. This is just kind of like an open discussion, so I guess we can go down the line. What is one word that describes your role on the dialysis team? This is for all of us.
Can you hear me?
Yeah.
Thank you. I'm an ex-Vietnam veteran, so in putting words of what we technicians are, and I'm kind of disappointed that technician wasn't a choice.
Yeah, Oh, you just can't see it. I'm sorry.
Oh, okay. I forgive NKF. Like I said, I'm a Vietnam veteran, and so the word that comes to my mind of what we technicians are in our industry, we're the grunt. We are really the grunt. We do everything and anything you all tell us to do. We'll put your patients on. When you need someone to go run to the lab, hey, Danny, can you take this to the lab? Hey, Danny, could you check the water treatment system? Hey, Danny, could you do this? Can you get us some 4x4s? That's us. We're the grunt. So that's my one word.
Okay, my name's Judy Kirk, and I'm a registered dietitian in the unit, and I guess the word that I would say is dependable. Because if somebody needs something, they say, tell the dietitian, she'll just figure out how to get it done. It's if somebody needs food, or if somebody needs a medication, or if somebody needs to tell the social worker or the doctor a message, just tell the dietitian because she'll find a way to get it done. If she don't know herself, she'll always find a way to get it done. So dependable.
I definitely agree with both of those. Like I said in my intro, I'm kind of playing a dual role here. I have a lot of experience as a dialysis charge nurse in like a very large inner city unit, and now as an APP, I'm the provider at that very same clinic as well as some of the other clinics. So as the charge nurse, I would say the best word to describe that role is firefighter. Particularly in the large inner city unit, we had 33 chairs and I had 3 shifts of patients. So my days were very busy, and it often just included constant triage and moving things around, and there was always things coming at me and always problems to put out. So just a vast array of problems coming at us. So firefighter is probably the best word for that role. And then as in terms of being a provider, probably just a signature. A lot of times the charge nurses just text me and say, hey, can I do this? Or this is what's wrong. What do you want to do? And I just give a quick order and that's it. It's far, far easier to be a provider than it is to be a charge nurse. So that's probably one word for each of those roles. Val didn't have these polls up here for some reason, but there are, I guess I can just go amongst the 3 of us. How long have you been working in a dialysis setting?
I think I started in the dialysis setting in 1995.
Okay.
Okay, do the math. Maybe it's more than 20.
51 years.
Wow. Yeah, he beat me too. I started in 2011, I think.
Yeah.
And then the last question is, at your current place of employment, do you round together?
Yes, the dietitian and the nephrologist round together. And the social worker is available nearby, and we round right in the unit, so the nurses are readily available right there.
Unfortunately, in today's technology, it kind of interferes with rounding together. Machines now tell you or does their blood pressure, and if it doesn't alarm, that patient may not be seen unless there is an alarm of that machine. So technology has interfered with us rounding together. When I first started in dialysis, way back when, we did manual blood pressures, we rounded, and our assignment was the person taking the blood pressure and doing the readings were doing the physical work. My partner would be walking around with the flow sheet documenting it. And so every interaction on a patient station had 2 people paying attention and looking at that patient. That doesn't exist now, unfortunately. And it's sad that, again, as caregivers, we're relying more on the machine to do what we used to do, which I think is wrong.
Mm-hmm. So at my clinics, yes, we also round together. And I found it very beneficial as a charge nurse, and I also find it beneficial as a provider because often the staff in the unit know the patients, they know what's going on. I walk in once a week and, pop in and check on everything. But they are the ones with, boots on the ground. They're seeing the people every day, knowing what's going on. And oftentimes, even if the nurse is on break or whatever, I'll pop my head in and say anything I need to be aware of, anyone have any issues going on before I go out there. I go around and then come back in and kind of, recheck in afterwards. So there is always some form of, teamwork, at least multidisciplinary communication going on during rounds. So we do find that very helpful. Okay, the next question is, if someone shadowed you for a day, what would surprise them about your role?
I did give some thought to this, and I would say that they would be surprised at how much the dietitian is involved with the total care of the patient, not just the food intake. Because I can go through my day, and then somebody's going to come to the door and say, "Oh, Judy, can you take care of this?" Or somebody didn't take their binders, or somebody needs this, or they would just say, "Well, I thought we just taught them about, their potassium or phosphorus." I said, "No, you actually get involved in all of the interdisciplinary aspects," and I think that would be surprising to them.
Yes. As a technician, it depends on the day. And the reason why it depends on the day, and actually it depends on the facility, because some of us work 2 full-time jobs. And there's reasons why we work full-time jobs, but that's another matter. But if you were to follow me on one day, I would be just assigned to patients and doing patient care and doing all the things that's necessary for that patient. We inspect and we look and we cannot assess, which to me is somewhat interesting, because everything that assessment does, we do except for reacting to the review instead. So semantics, we do everything. So if you follow me, I do my patients, but on another day, if you follow me on another day, I'll be assigned to the back room doing the water checks. Or if you follow me another day, I'll be there responsible for the supplies. And so it's very dynamic and very varied as far as what our typical day is, at least in my unit.
Speaking as someone who had a lot of experience with a lot of different techs across my years, I think that you are maybe legally correct that you can't assess. However, I often rely heavily on my techs, particularly my experienced ones. They were often, dialysis is unfortunately kind of there's a revolving door for nurses. They come in and kind of use it as an entry-level job, and a lot of, at least in my area, they don't stick around very long. So a lot of our techs are far more seasoned, far more experienced, and for a lot of our long-standing patients, they have really great relationships. I relied on my techs both as a charge nurse and still as a provider now. I know my techs know my patients very well. So legally speaking, maybe you're not allowed to assess and you're certainly not allowed to act on it, but I trust your opinion. And if you come to me and say hey, they're not acting right, I'm gonna listen to you. I don't know, as from a charge nurse point of view, something that's surprising is, I don't know, maybe it's not surprising, but just, again, like Judy said, kind of how much we do. It's everything from, putting people on the machine, doing meds, doing assessments, but also calling people and making sure that they're okay if they're not coming in, doing wellness checks on people, calling family members when something is going wrong, following all the doctor's orders, calling the doctor when they're not there that day and saying, hey, this is what's going on. Can this wait? Can this not wait? Going through stuff and getting ready for grand rounds and, compiling lists of signatures and things like that. There's so much that goes into it. And I think that especially in dialysis, in terms of the provider role, we're not primary care, but we do see these people every week. And oftentimes they need something from a provider. And it's really hard to get into a PCP, even when you have an established one. And, the patients are often asking things of us that are not dialysis related. They just need a doctor to do them. And it's do I take off my nephrology hat and kind of do this that's I'm not maybe the best person to do it, but if I don't do it, it probably won't get done. So like, what's best for the patient? So I think that, maybe in the role as a provider, we do a lot more non-nephrology related things probably than we should, but also if it's what's best for the patient and it's not going to get done otherwise, I'm happy to do it. So next question, where do your roles intersect the most and how do you make that overlap work smoothly?
I think the place where my role intersects the most is in regards to medication. The phosphorus binders, the potassium binders, the vitamin D therapy, the calcimimetics, because as a dietitian, I'm assessing all of those with the monthly labs, but the nurse, with them being in the bundle, they come into the unit, the nurse has to give it to the patient has to take it, the doctor's orders have to coincide with everything going in, and it just brings in a multitude of people to collaborate with in order to just have the medication ordered, dispensed, the patient adherence with it, and any kind of complications and alternatives and things. So it's just opens a whole spectrum, and I think that brings in nursing, social work, dietitian, nephrologist.
Yeah. Obviously, where it intersects the most is at the treatment area. and we technicians think of ourselves as the eyes and ears of the unit because we're there in front of the patients, and our interactions and intersections is that when there's things that we need to bring to the professionals that we're not trained with, that's where we intersect, and we have those roles. Conflict management is not my area of expertise, so we have great social workers that help us with that, and they even lecture to us that. I am clueless about medications and diet, so when there's issues and questions from my patients I cannot answer, that's where we interact and work together in actually taking care of a patient.
Well, Danielle, I actually depend on the technicians a lot as well, because you guys are there all the time, and the patients trust you and can also tell you things that they may not think of telling me when they see me. And I have a lot of technicians say, hey, Judy, so-and-so really doesn't like that binder that you give. Can you talk to them about getting a different one? So, I rely on the technicians a lot because the patients trust and talk to you a lot.
I knew a patient that was with me for 35 years. Never had a transplant. He was on dialysis for 35 years. Wow. I knew his wife, I knew his kid, I knew everything about him. And that's not professional, I'm told, but that's okay.
I think, when we see these people for hours, 3 times a week, you do become a part of their family. There's often blurring of that patient personal, professional relationship, and I think to a certain extent that's okay, they rely on us, we are their lifeline. I too have had, I've been to funerals of patients, I've been to funerals of patients' family members because they also felt like part of our dialysis family. We've had patients who brought in Christmas presents for the staff, homemade goodies, and some you eat and some you don't eat, and I had all 2 of my 3 babies while I was a charge nurse, and I had patients bring me in gifts and send things home with my friends from work to gifts for the baby afterwards. I've shared recipes with patients and their family members before. You get to know them, you're a part of that. You see them for 12, 13 hours a week sometimes. You become part of their life, just by default. So I think that, all of our roles obviously intersect at the chair side because the patient is kind of the center of everything. In my role as a charge nurse, at least the way we kind of run our units is the charge nurse is the linchpin of everything. And, we have techs coming to the charge nurse with, things, what a water treatment issue that I then have to relay to the medical director. We have dietitians coming saying they don't like their binders, but I need a telephone order to go off algorithm for this. So can you get this the next time you talk to the physician? And then the social worker is coming saying this person's not eligible for rides, so they're not coming to their next 2 treatments until their rides kick in on Monday, or, and then I have to call and get orders for that. So I think, at least the way we run our units, the charge nurse is kind of like the one-stop shopping. Everyone goes to the charge nurse for everything, and then we kind of filter out. So we do kind of have a hand in everyone else's role in the unit as well. And then as a provider, the flip side of that is I rely heavily on my charge nurses to let me know the goings-on of the unit. It's really easy to walk in, everyone's on the machine, and I just stop, say hi quickly, look at everyone's labs, their blood pressures, ask them if they need anything. But, oftentimes I walk away from the chair side, and then, the nurse will say, hey, they had an issue that the patient didn't tell me about, and, then I go back. So I think to Daniela's point, our roles all intersect at the chair side. Anyone else have anything to add before we move on? Okay, what strategies help your team communicate effectively during rounds?
I think in my experience in my unit, I think what helps us is the open communication. We value each person's expertise, and we will just include everybody's input, the nurse, the technician, the social worker, even the front desk people know these patients very well as well. So we don't have any thoughts of hierarchy of one person over another. Everybody is a value, and the open communication and respect for everybody's opinion.
Yeah, I think that's a great point of hierarchy. In our facility, if you don't look at the color of the scrubs, you can't tell what a person is by the function that they do. Because again, once you hit that floor and the treatment starts, nurses and technicians are doing exactly the same thing in taking care of that patient, except for, again, medications and in some states, catheters. Some states allow technicians to do catheters, which is interesting, that one state allows and one state does not. But communications in our facility is not really done that dramatically, except at the beginning where we do huddles. Every time we start each day, we huddle and discuss patients and make our plan of treatment for those days. Once you hit the floor, we have a pod system. Each pod has 2 technicians and 1 nurse, because each pod is 8 stations. And they communicate with each other and actually perpetuate what was shared that morning, and that's our communications. Yeah.
I think that trusting everybody in their role is huge. In the unit I worked at when I was a charge nurse, it was in a not great area of town, and we actually had a security guard who was, contracted from some local security company, and I can't count the number of times even the security guard would come in and say, hey, this person's here a half hour early for their treatment, but they don't look right. We had one patient who liked to take, he was second shift, so he would come in a little bit before lunchtime, and he liked to take his insulin at home, come to the unit, sit in the waiting room, and order lunch to be delivered, and then get on the machine and then start eating. And oftentimes his insulin started working much faster than he got his food. And a number of times we cannulated him while he was passed out on the floor of the lobby and stuck a needle in his arm to give him some dextrose because he was crashing. And, if it wasn't for someone listening to the security guard who has absolutely no credentials in healthcare whatsoever, he just got assigned this gig, that patient could have had a really adverse outcome. But, even trusting just listening to everybody, respecting everybody as a valuable member of the team. I saw everybody on my team as just as important. I had a ward clerk, and there was a clerk at the front desk as well, and the security guard, and to me, they were just as valuable at looking at the patients and eyeballing them and relaying information to me, as was the biomed tech who was helping me when, someone didn't transfer the bicarb up and every machine in the unit is beeping, and all my techs who, have all these tips and tricks for, everybody is a valuable member of the team and everyone has something to contribute. And as long as everyone on that team can know and respect and understand that, I think that's where you get, that's where the patients benefit the most.
Yeah, and just to add to that, I had an experience where, we have some staff lunches and things, and the nephrologists, the dietitians, the social workers, and the nurses and everybody is in. And one of the nephrologists went and invited the housekeeper and said, come, sit at lunch with me. You traditionally only get invited for the setup or cleanup, but if you didn't keep this environment clean, I couldn't do my job. So come sit next to me.
That's really nice. Can you share an example of when collaboration improved patient outcomes?
Yes, I thought of an example recently. The nephrologist and I were rounding in the unit, and there was this one patient who frequently did not show up for his treatments. And, people had labeled him as non-compliant, doesn't care. So we just spent probably 15 or 20 minutes with him and said, what is the reason you're not coming? And as it turned out, his primary reason was that his transportation company wanted to get him to the unit an hour and a half before his treatment based on their transportation schedule. But then where the interdisciplinary team came in, the social worker came in, but the instrumental person in correcting the problem was the front desk clerk who said, I know which companies say that, and I know which companies will get you there 20 or 30 minutes ahead instead of an hour and a half ahead, and which drivers are like this and which drivers like that. So she paired him with a driver who met his expectations of how much earlier you need to get there, and his attendance at treatment improved dramatically.
Yeah. Collaboration is something that we do at my hospital quite well, in that several years ago, quite a number of years ago, I developed what we call a clinical ladder for technicians. And that clinical ladder requires collaboration with a nurse on a project, a QA/PI project, a quality incentive project, like vascular access, emergency preparedness. So they have to collaborate. And in order for the technician to actually climb that ladder, he needs a sponsor, and that sponsor has to be a nurse. And so the two of them are, I don't want to say mandatorily, but the technician makes her collaborate because he wants that raise. So that collaboration exists to this day, where a technician, in order to advance, is given the project, and then the nurse and the tech work on that project for quality improvement. Yeah.
I'm from New England, and several months out of the year, we frequently have snowstorms. So I remember there was a Sunday, and I was grocery shopping because we were supposed to get a big storm, and the storm was supposed to start Monday evening and snow all day Tuesday, and they were predicting 24, 26 inches of snow, something like that. And I remember I was grocery shopping early Sunday morning, and the clinic manager called me and said, hey, do you have 20 minutes? Can we chat? This is what we're going to do. And we decided that we were going to take all of the Tuesday, Thursday, Saturday patients, move them up to Monday, and close Tuesday for the safety of everybody, our drivers included. And we were going to do 140 treatments on Monday. So we started by saying, which of my first shift patients, and their first shift started, our first put on was 5. So we said, which of your patients drive themselves? Because we have to make a list of who needs our transportation to, change times and days and things like that. So we started with our patients who drove themselves, and we had them come in at 4. We had our opener come in at 3 and open, and our first put on was 4. We shortened everyone's treatment by an hour, and then we just started slow rolling, and we moved all of the Tuesday patients onto Monday. So first treatment was at 4, and I think our last patient got off the machine around 11, and they should have gotten off probably a half hour later, but we had to stop them because the last cab, they made one round of pickups at like 10:30, and they said, we're coming back one more time, and we'll pick up whoever's left, and that's it. We can't come back anymore, because there was already like 5 or 6 inches of snow on the ground, and it was getting really dangerous. And that's for anyone else who lives in a climate with snow. You get those fun letters from Fresenius faxed to you, and it's like, take this if you get pulled over by the cops, because they've closed down all the roads and the highways, and for essential personnel only. So you get that letter that says, yes, you are essential personnel. That's when you know it's serious. But that day required, we called the ride. We scheduled hundreds of treatments. We rescheduled hundreds of rides. We had family members coming. We had staff members come in early, leave in the middle of the day, and come back and help at night. We had, way more staff members on the floor than we were allowed to have, but it was just the most all hands on deck I've ever seen. And I was like 5 or 6 months pregnant at the time, and it was the longest, craziest, busiest day ever. And it was so hard when we were doing it, but every time, we all get together and reminisce, everybody is, in, complete agreement. That was our hands down our favorite day at the unit, because even though it was chaos, everybody just knew it was all hands on deck. Everybody can do whatever they can do. We had nurses and techs putting people on. We had, social workers calling rides. We had the security guard wheeling people in and out, getting people out in cabs. It was crazy. But everyone just kind of pitched in and did whatever they could to help. And we only had like a handful. So out of like almost 140 patients, we only had like 3 or 4 patients miss rides or not be able to come that day. And they ended up at the hospital, and they were totally fine. But it was absolute chaos, but it was great to see just how much you can accomplish when you realize that, if you use each other and you rely on each other as teammates, we can really do great things. So it was chaos, but it was very fun. What is one unwritten rule of dialysis rounding that everyone knows?
Well, it's kind of funny. There's limited desk space in the unit, and actually, for some reason, there's limited chairs. It's like you kind of steal a chair, or whoever, its possession is 9/10 of the law in there. But the unwritten rule is that the day the dietitian and nephrologist is rounding, they get the prime table and they get the good chairs, and nobody touches them. It's set up, and everybody knows, hey, they're rounding today, don't touch those.
Yeah.
It's kind of funny, but...
I think that's the same everywhere, because we have one rounding stool that we're not supposed to use because Dr. X wants it and needs it. Needs it. But I think for us, the one unwritten rule for us is look, listen, and speak. I think that's pay attention to your patients and pay attention to your surroundings. That's the one unwritten rule, because we can kill our patients for non-attentiveness of a dislodged needle. So we gotta have that as part of our standard rule. Mm-hmm. Look, listen, and yeah.
Well, maybe we need to, position for more stools, because those stools were always a hot topic in our unit too. And it was like, it was first come, first serve, and everybody raced to the floor just to get the stool. But If you ask me when I was a charge nurse, I would say that the rule should be that everyone should just listen to the charge nurse because, like, again, we were kind of like the way that we run our units is everyone kind of uses that charge nurse as the sounding board, and then we kind of filter out, you know, what information goes where, how it gets done, you know, making sure all the boxes are checked at the end of the day kind of thing. So the charge nurse was pivotal there because, you know, everybody comes to us and says, like, you know, they have this issue at home, whatever, and then 3 treatments later when the physician comes back to round, I'm supposed to remember to relay that information because, of course, the patient is sleeping or forgot or whatever, but it's my job to relay that to the physician or, you know. And then as a provider, I think it's really important that, you know, it's easy to walk in and look at a blood pressure, look at some labs, and then say, like, do you need anything today? No. Okay, have a great day, and move on. But it's much harder and much more time consuming, which, you know, obviously none of us have the time, but I think it's really important to kind of find some piece, something to connect with our patients on. I remember when I was a nurse, the patients would always say, like, oh, like the doctor asked me, you know, about my daughter's graduation or something, you know, like, and they always found it so personal and it seems so silly. But so I have one patient who loves fishing and he goes to Cape Cod for the whole summer. So we arrange treatments for him at another clinic. And he goes fishing, so I always am talking to him about fishing, and you know, he asked me to, I said, oh, we took our kids fishing after work yesterday, and I show him a picture of my 8-year-old holding up a smallmouth bass, and you know, just something like that, or connecting with a patient about, you know, a trip that they took, or just something. And, you know, we have to remember that at the end of the day, there's still people, and they, you know, it's easy to get caught up in, you know, all these treatments and all these appointments that they have because they still have other appointments and often a lot of them outside of dialysis, and it can kind of become their whole life. So to talk to people just like they're people and kind of have some kind of human connection, it really, really goes a long way. So as a provider, I really try and kind of make some kind of, you know, and not with every patient every day, but, you know, if they're sleeping, sometimes I let them sleep and sometimes I wake them up and say, how was that baseball game? Or, you know, did your daughter have the baby yet? You know, just something. So I think that can go a really long way.
I think another unwritten rule is I'm 75 years old, and it should be that the oldest person gets the best, easiest patient to take care of.
And the chair.
And the chair.
And the chair,
And
yeah.
the chair.
Because all of my nephrologists are at least 20 years younger than I am.
Yeah. Football's always a good connection, too. I'm a big Philadelphia Eagles fan. I grew up in Philadelphia. And obviously I conflict in Rochester with the Buffalo Bills fans, but football's always a big topic for at least 7 or 8 months of the year.
Mm-hmm. Yeah, I think it's really important, and even unofficially, like we've had, you know, we make wagers with patients, you know, and it's like, you know, you have patients who are, this was more like as a charge nurse, but I had, you know, patients who was really struggling with like a phosphorus or a potassium or something like that. And, you know, like, I bet you can't get it down, or, you know, like, it was something like that. You come up with some kind of fun, silly wager and, you know, like, I'll buy you a treat from the vending machine if you can get your phosphorus under 10 for 1 month or something, like, you know, like just something to kind of make it more human and make it more personal, and let them know that, like, you really do care. You're not there to just stick them with needles and check their vitals and send them on their way, you know, like, we are their lifeline and they rely on us, and it's really important that they know that and they feel that too. And it goes a long way with their families as well. Like, we've had patients recognize the dialysis center and the dialysis staff in obituaries. Like, when the patient dies, the family, you know, specifically thanks the clinic in the obituary. And, like, that can really mean a lot to the staff as kind of like closure from our standpoint too, because some of these people we've been taking care of for years. We had a patient who was, I think, 35, 36 years, kind of same thing. And I remember we actually, at one point, they had to reorder everything in E-Cube because his original date of first dialysis was so far back that E-Cube didn't think it was possible, and we had to call E-Cube and get special, I don't know, something because they didn't believe that he could have been on dialysis for that long. So we had to reorder everything and readmit him. So with people like that, all that can go a really long way.
Yeah, it builds trust.
Yeah, I think it's important. On their side, too, it's good for the families to know that, when they drop off their loved one or when they put them in that transportation vehicle and kind of send them on their way, that they're in good hands and that we actually do care about them as well. So that can be really nice for the families aspect of it. This is a good one. If your dialysis unit were a reality show, what would it be called?
Well, this one I did struggle with a little bit because I don't watch reality shows, but I picked a game show instead, and I picked Family Feud. Because we are a family, and we don't always disagree on the same way of doing something, but in the end, just like in the game, the family huddles together, they discuss it, and they come up with an answer to present and move forward with. And I think that does happen a lot because different people and the different disciplines will say, well, let's do it this way, or let's do it that way, or how about we try this way? And then the consensus is made and a plan is moved forward, then reevaluated after that.
Well, mine's not reality either. It's a sitcom. And the sitcom, I don't know if you're all familiar with the NBC series Superstore.
Oh, that was a good show.
Yeah. Superstore was made up of so many different personalities, characters, and backgrounds. And our dialysis unit is the same way. And obviously, some days it's so hectic that we try to tear each other and kill each other. And then another day, it's so jovial and joyful, and we're laughing. So Superstore is our unit.
That was a really good show. I didn't necessarily pick a reality show either, but I guess it's a show. But we always joked that we should write a book about all the stuff that happens at dialysis. So I would call it, something like, Ripley's Believe It or Not, like you're never going to believe this. We had like all the funny things. We had a new patient start dialysis, and the patient's mother called and said, "Can dialysis patients wear deodorant?" And I remember thinking, like, yes, and we actually encourage it. Yes, I had one guy came in. And he put just a plastic, like a grocery store bag, and he walked by the charge nurse counter, because the charge nurse counter faced the whole unit, and he walked by and he just put it on there, and I was thinking like, oh, well, what are you bringing me? Sometimes the patients would bring us in little treats or something like that, and I opened it, and there was his perm cath just sitting in the bag, and I was like, what would you like me to do with this? And he said, I go sit, you put it back in. And I was like, nope. Do you remember when you went to the hospital and a surgeon and an anesthesiologist and you in a sterile operating room when they put that in the first time? That's how it happens every time. I can't stick that in there. I had another patient, his perm cath fell out at the scale. He took off his jacket and went and just boop right on the floor. I had another patient call, and she told me that she wasn't going to come because her elevator was broken, and it was going to be fixed in 2 weeks, and she would come back then. And I was like, well, it doesn't work. Let's see what we can do about getting you an alternative ride. Just all kinds of crazy stuff. I mean, you wouldn't believe it. We had one of the other local clinics had to urgently close briefly, and we had to admit, I think we stayed until 11 or midnight, something like that, admitting all of the patients from the local clinic because they found a raccoon running up around in the in the ceiling, in the crawl space above the ceiling tiles in the unit, and they had to call some sort of large animal exterminator and get someone in, and the patients obviously couldn't be in the building while there was a raccoon running amok. So it's just the craziest stuff happens, and I don't know, it always makes for the best stories. So
I think everyone has that kind of story.
Yeah.
We did have somebody on Jerry Springer show, a patient that was on the Jerry Springer show. She did have an interesting home life.
I've had patients get in fistfights before. They were both hooked up to the machine, sitting next to each other, and they stood up and they started fighting each other.
We had one nurse, and for nurses, be careful when you're accompanying a patient to the scale. Okay. She accompanied a patient to the scale, and he started passing out, and he was going down. And the nurse went and tried to, but the problem is, on his way down, he grabbed this. And on his way down, he kept it. And she yelled. And when we came, in all her glory. So be careful at the scale room.
All kinds of stuff. But that's what keeps it interesting, right? That's what keeps you
51
coming.
years, I could tell you some stories.
Yeah, it's what keeps you coming back. Who is the glue that keeps your team together and why?
Well, in our unit, I would say the nurse manager, because there's a lot of times something comes up where, well, I thought she was supposed to do it. Oh, I thought he did it. Isn't that her job? So it sort of ends up at the nurse manager's desk, and she politely accepts the buck stops here and comes up with a solution, and then we all move forward.
Yeah, mine's easy. Is that father, that mother, that brother, that sister, that friend that's sitting in that chair. You know, it's not a patient, it's those individuals. And that's the glue that keeps us together. Therefore, by the grace of God, go I. And I'm going to treat that patient as if it was the most important thing. And anything that happens is the glue that keeps us together. I don't want to be sick one day and say I'm too tired to go to work, because that person in that chair is deserving my attention. So it's such a strong glue to keep you doing what you're supposed to be doing. Yeah, so that person, not that patient, that person.
I mean, the answer that I thought of wasn't prepared quite so eloquently, but my answer was the patients, you know, like they're the reason we all show up every day. They're the center of what we do. We're all there in our various roles, often assuming other roles that we didn't know we signed up for, but it's all for, you know, that patient, that person in that chair. That's why we're all there. And it can be easy to forget that sometimes in the midst of, you know, following all of the checklists and things that we have to do and making sure we're filling out all the water logs and all the, you know, all the assessments and all the foot checks and all the things that we have to do. But all of it is for those people, to keep them alive, because they rely on us. We are their lifeline. So I think that sometimes it's easy to forget, but we need to remember that.
Yep.
So yeah, that was the last of the prepared questions. So I was going to say now we can take questions, and there's some in the polls, but go ahead.
May I ask Mr. Danilo, in your years of experience, what allowed that person sitting next to the patient to be present?
I'm sorry. Remember, I'm 75, and the hearing is one of the first things to go.
Thank you for your talk, everyone. I'm Yusuf Jalul, one of the nephrology fellows at Albany Med. I wanted to ask you, in your years of experience, what factors allowed that person to be sitting next to the patient? What are the different factors that allowed their presence to be feasible and their support to be possible?
I'm sorry, what allowed the patient to...
To have a companion sitting next to them.
Companion sitting next to him? Yeah. Is that a question? I'm sorry.
Oh, you mean like the patient's
you said the patient,
family member?
Right.
Oh, yeah. Do we allow them to be companion, or what?
No, I'm saying which patients have these this company with them?
Which patient has a company with them?
Yeah.
Some have, some don't. And again, some of the family members are not comfortable actually sitting where there's a lot of blood. And some family members are so overprotective of their loved ones that's on dialysis that they will literally sit there, take every little note and every little nuances of the treatment. So, and some of our patients, again, have loved ones sit the entire treatment sitting there for the comfort of that person there, because that's one of the things that makes them comfortable. Did that answer your question?
I think he misunderstood when you said that the glue that holds the team together is the father, the brother, the
Oh,
sister.
I'm sorry.
Yeah.
I'm sorry.
About the patient
Yeah,
and
I
not
was.
calling it
Yeah,
patient,
yeah.
calling it who
Okay.
Yeah, because again, we tend to sometimes forget that that person sitting there is a father, is a mother, is someone's brother, someone's friend. So it was that analogy I was using. Yeah, it's not so much. Yeah,
Thank you.
I'm sorry. Okay, so that hopefully that now answers the question. Yeah. And by the way, if you didn't hear David Rush's lecture yesterday, he's a patient advocate. That was one of the words that he was using, so I plagiarized him and used it myself because I thought it was fantastic. And actually thinking of the person in that chair as a father, as a mother, as a brother, as a sister, as a friend. Yeah.
Mm-hmm.
Yeah.
One of the questions that came in was, do you have any experience with patients with paranoia? We have a patient at our unit that firmly believes we are poisoning them and it's a hostile environment.
We had one that had the 357 Magnum, and that's how paranoid that person was. Mm-hmm. And unfortunately, as soon as we found out that he was packing, we obviously had to report it. But he thought that at any given time, someone might do him harm, so he was going to do them harm first. Yeah, literally a 357 Magnum in his bag, and we didn't know it. That was before all the security things happened. Yeah.
Mm-hmm.
Yeah, those are difficult patients, and they come along once in a while. I think they've had 2 or 3 incidences in my lifetime of being a dialysis dietitian, and just a whole team approach, and security is part of your team, and just dealing with decisions and administration is part of your team, and dealing with decisions on what you are truly capable of managing in your unit versus what you're truly not capable of managing, and coming to a decision of it has to be a safe environment for all the staff and all the other patients.
Yeah, we've also had another patient bring a gun in, and a lot of the Springfield PD descended very quickly upon the dialysis unit. I've had other patients firmly believe that we were poisoning them, like the water treatment area is obviously separate from the patient treatment area, and they thought that one tech in particular, this patient really just had a tough time with, and every time that tech went back in the water room, the patient, started, insisting that they were feeling all of these symptoms, and they were saying that, he went back and he was poisoning them and things like that, and those patients can be really, really tough. They can be very challenging. And I think that, you do the best you can with education and letting them know things like, like the water treatment and back, it's the same water system that goes to every patient. So it would be impossible to do something to just you from the back water room. We would never hurt you. I think we've had patients like not accepting of med changes before, like all kinds of stuff. And I think the best that you can do is pre-education goes a long way. Like I remember when we were switching from Epogen to Mircera, having like talks ahead of time with those people and kind of like letting them know you're on their side and you understand their fears and whatever their issues are. Doing the best you can at educating them ahead of time and kind of working together and trying to phrase it as though we are on their team, but making sure that they really understand that we're there to take care of them and not to hurt them. Yeah.
I was just going to say, make sure you document it.
Yes, that too.
Yeah. Because when they report,
Mm-hmm.
which they will,
Yes.
You have to have everything that you've offered them, psychological resources,
Mm-hmm.
that you've discussed it, that doctors particularly discussed it with them, and that, do everything you have to do to protect your team, but make sure it's well documented.
Yep. We actually, we had an involuntary discharge, the patient who had claimed he brought a gun in. We actually involuntarily discharged him. And when DPH came in for their audit, they had asked us, do you have any involuntary discharges? And we said yes. And they went through and, they said, we actually don't even need any more information on this. They said it's so clearly, so well documented. I mean, some of his...
With a gun,
Yes, some of my charge nurse notes would be like this long with, multiple paragraphs of, lots of direct quotes with very vulgar things. But, we put it all in there so that by the time we actually did, go through with the involuntary discharge, it was very clear that it was necessary to protect the safety of the staff. He was following staff members outside of work, following them, and then they'd come in the next day to work, and he would say oh, I saw you yesterday, you were wearing this, this is your license plate, this is your car, really, really inappropriate behaviors. But we had it very, very well documented, and so it was.
Yeah. We had somebody who was a drug dealer who was conducting business while he was on dialysis.
Oh, yeah.
So lots of documentation went in that, and we did end up with the involuntary discharge there as well.
Mm-hmm. We had a guy who was an inmate. We're the local unit who was contracted with the local correctional institution. So we had a patient who was an inmate, and he had friends from the outside come in and visit other patients who they didn't even know, and he would go in and use the bathroom, and the friend would hide drug paraphernalia in the bathroom, and then when this guy who was the prisoner came in, he would go to the bathroom before or after his treatment, and he would find the hidden stuff and take it back to prison with him. I'm sure you can imagine where. And we ended up having the jail staff come and interview all of the dialysis staff, because it became this whole investigation. They were listening to his phone calls at jail and figured out that this is how he was getting stuff in and out of jail. And it became an issue. So if you can imagine it, it happened. And even if you can't imagine it, it happened.
It happens.
We've had that same exact example happen at clinics that we worked at together.
Mm-hmm.
But one thing I wanted to say about the paranoia, we had a patient that was paranoid about different things. But it turned out I was a social worker, she's a dietitian at Fresenius. I don't work there anymore. But we had a further conversation with him, and it turned out it was religious type things.
Mm-hmm.
So he didn't want certain medications, or he didn't believe in having blood.
Mm-hmm.
He didn't understand certain things, but it was because of his religion. So we had to have those conversations with him.
Mm-hmm.
But
Yeah. I think at least in my experience, at least some part of their paranoia or their fears come from maybe a lack of understanding about certain things and what we're doing and why we're doing it. So if you can really just sit down and spend the time with them and educate them and answer all of their questions, generally they can come around. Obviously, there's people who just have psych issues and they're paranoid, and you're not going to be able to rationalize no matter how hard you try. But I feel like you can solve, at least some portion of, misunderstandings or behavioral issues like that with just, time and repeated effort and education. I think this was a second part of that, but to follow up on that, it says he has been banned from every other unit other than ours in education, and therapeutic communication usually does not de-escalate. So, unfortunately, you do what you can. We have had patients in the area who were banned from every local dialysis unit, and unfortunately, they just go to the hospital 3 times a week and they dialyze. They show up in the ED, and we kind of have a fast track from the ED right to the dialysis unit. But, we're working on behavioral plans. But it's been a few years now, and it's been several patients actually. But, there are some patients and they're just, they kind of, you give them an inch and they take a mile, and you do it one too many times and they've lost their spot. So, that's all you can do is you have to protect your staff as well. Going on with that, examples are Venofer is black poison, Mircera is poison, the dialyzer setup was tampered with. They were just curious if anyone else has success in improving things in this kind of scenario.
Some work and some don't. You do the best you can.
I'm sorry, I didn't get the question.
Oh, it's like, it was I didn't realize initially that it was like, it looked like 4 separate questions, but it was really just one long run on, because I think you're character limited. So the examples of the patient who was paranoid was that like Venofer is black, so it's poison, or Mircera is poison. They set up the dialyzer, then tampered with it. Whoever asked the question just said they were curious if anyone else has had any success in improving anything in this area, like with patients who are paranoid or accuse us of trying to harm them.
Yeah. Well, in that respect, mine was only in the technology portion. There was actually a North Carolina incident where a fired technician literally poisoned the holding tank and is now serving quite a long prison term.
Wow.
Yeah, and that's why the water treatment room has to be secured and locked and accessed for only authorized individuals. Yeah, he literally got fired, and they took away his badge, they took away his entry, but the problem is the facility did not inform the housekeepers.
Oh.
So guess who let him in? The housekeepers. Yeah, so that's the only thing I know about poisoning. This fast.
That's tough. Yeah.
That was real. Yeah, it's not paranoid.
I think we're just about out of time unless anyone else in the audience has any other questions. No? Well, thank you guys so much. This was great, and I think it's always great when, it's one of my favorite parts about the NCAF is it's inclusive of every specialty. I think, dialysis wouldn't work. It's not just nephrologists. Like in the roles that I've been in, being the provider is by far the easiest one. Being in the clinic every day is much, much harder. So I think that's why I love this organization so much, is they do, recognize and respect the work of techs and social workers and dietitians and nurses and everyone in the roles that we play in dialysis, not just the providers. So thank you guys all for your time. Thank you everyone for coming.
Thank you.
Hope everyone gets home safe.
Thank you.